Hello, my name is Michael Rothman. I'm the Chief Science Officer at ParaHealth. The talk today is Intelligent Clinical Surveillance Shows Reduced Mortality in a Randomized Clinical Trial. My co-authors, Catherine Walsh, Shannon Hamlin, and Belmet Askare are from Houston Methodist, and Joseph Beals from ParaHealth. Why have an early warning system? And why do most such systems fail? Let's talk about the need for early warning. Well, first of all, most hospital visits proceed as planned. If there are complications, they're attended to in a timely manner, but for a significant minority of patient visits, this does not happen. These patients do need better care. They need early warning. And why have early warning systems largely failed? They just don't impact outcomes. This is because they're based on vital signs, and they warn during the decompensation process. Decompensation is when your vitals are failing. But at that point, it's too late to avoid a crisis. You're already in a crisis. And the information is old in that the nurse and the doctor already knows that there's a problem. You're not adding new information. Can't affect outcomes. In order to affect outcomes, one must go beyond vital signs. I call it hitting the value trifecta. A warning must be correct. If we say you're sick, you must be sick. Must be timely. If there is an imminent problem, we have to warn the physician, the nurse, with enough time to intervene effectively, but it also must be new. It can't be a problem which the nurse or the doctor already knows about. It has to be new information. Now, the Rothman Index is a measure of patient acuity based on machine learning technology, and it's been validated. Many studies, in addition to vital signs and lab tests, it uses nursing assessments. Nursing assessments are structured evaluations that nurses do for each patient, for each shift. They rate about a dozen physiological systems. These assessments, this additional longitudinal data stream, captures functional fails. Loss of appetite, confusion, edema, trouble walking, failure of digestion. These failures tend to precede decompensation during what I would refer to as the compensation process, when your body is trying to compensate for challenges. This kind of a system can hit the value trifecta. Nurses at Houston Methodist Hospital ran a randomized clinical trial. They used the Rothman Index, which provided what we refer to as intelligent surveillance. It was implemented on intervention units. Historical as well as concurrent controls were used. The Rothman Index is actually integrated into the hospital's EMR and updated in real time. This was a large study. 34,000 patients were included in the original controlled study and an additional 100,000 in a post-study analysis. One thing to keep in mind is protocols were essential. What do I mean? Well, monitors displaying the RI graphs, which is the Rothman Index versus time, and there's an example on the right there, for all patients on a unit were placed at nursing stations. Graphs were reviewed several times each day by the nurses. Some were designated by the system as high risk. Nurse practitioners rounded on those patients whose RI graphs indicated high risk, and protocols were established for also for the bedside nurses and the charge nurses to provide additional attention to patients who had triggered one of these warnings. After the study, these protocols were implemented across the entire hospital. What happened? Risk-adjusted mortality decreased 32%. On the left of that vertical line, you'll see two bars at 0.7. That's a mortality index. It's the actual mortality divided by the expected mortality. Houston Methodist, for about 3/4, was running at 0.7. They experienced 70% of deaths that were expected. But what you see is after implementation, the intervention unit, which is the darker bar there, mortality index fell to about 0.5. We affected change, it turns out, across the entire acuity spectrum. But at the core of all this, it means changing behavior. So what happened? Fewer patients deteriorated to a worrisome state, and those who did had a lower mortality rate. This is because physicians and nurses were aware of the patient's situation, they were aware of deterioration, they were given that new information. But affecting outcomes is enormously difficult, and it almost never happens. A system such as we've described is a start, but the end must be changing clinicians' behavior. And it turns out even when you're successful, you're not done, because high clinician turnover requires continual education. I hope this gives you some insight into the work that was done by nurses and physicians at Houston Methodist. Glad to talk to you more later. Thank you.